to today present our Grand Round speaker, Dr. Jim Mills. Jim, welcome. Dr. Jim Mills is Associate Professor of Cardiology. He recently joined us from West Virginia University. He's the Director of Preventive Cardiology. He is an imaging cardiologist, and he is developing the Center of Cardiac Prevention and Genomics at our institute. Dr. Mills did his postdoctoral and graduate training from University of Pittsburgh, where he also completed his cardiovascular fellowship. And he had a successful career in which he has gone through the ranks, academic ranks. And I personally met him when I was at West Virginia University, and I found him a really knowledgeable cardiologist, excellent colleague. He had a tremendous reputation in his work in terms of not only just his imaging, but also his reputation amongst the fellows as a great teacher, and also his professional activities in which he has had Castle Connolly Top Doctors accreditations, Press Ganey at the 97th, 90th, and 99th percentile, consistently Teacher of the Year award, and also a tremendous contribution to the development of the imaging program at the West Virginia University, where he was the director of the stress and the metabolic perfusion imaging. He has a specific interest in echocardiography, structural imaging, and also nuclear imaging, including PET. He has a good track record of research, industry sponsored clinical trials, and also successful publication. When I met him and requested him to join us, he expressed his keen interest in preventive cardiology, particularly with a recent attention to the field of genomics. And that's where today we will hear from him. His lecture is going to be divided into two parts. Today is going to cover mostly about the basic foundational elements with the diagnostic components, and then he's going to touch upon his therapeutic and pharmacogenomic aspects later on in 2026, May 11, in a second pair of series of Grand Rounds. With that, Jim, the floor is yours. We look forward to understanding and learning more about this rapidly changing area in cardiology.
Thank you, Partha. I hope you can hear me, everybody.
Perfect.
Excellent. And you can see the screen okay?
Perfect.
Excellent. Give me 1 second here. Well, thank you so much for that very, very kind introduction. And it's my pleasure to be here this evening and to talk to all of you about cardiac genetics. It's a pretty extensive topic, I must say, but we've planned to divide it up, and so we'll talk about that here. And I have nothing to disclose. And let me see if I can move this forward. There we go. And so I said, we're planning to divide our cardiac genetics grand rounds into two separate grand rounds. Today we'll be talking about the diagnostic evaluation of cardiac genetics and genomics. And then later in the spring and May, we'll be talking about and tackling pharmacogenomics and therapeutic interventions. And so this is kind of the extensive list of what we'll be speaking about today. We'll go over some basic concepts, and we'll just review genetic testing, just the basics of genetic testing. We'll discuss the difference between monogenic and polygenic assessment, and we'll dive into polygenic risk scores. And then we'll really take some time to talk about individual monogenic variants as they are related to diseases and what we should think about in our daily practice. And so I've told the fellows back in West Virginia, and of course I've started to tell the fellows here, that our future practice and their practice will be largely based on genetics, both diagnostically and therapeutically. And so we're in a time now of transition, where we're transitioning from the usual pathophysiology that we've used over the years, and now we're adding in cardiac genetics into our day-to-day practice. And it's going to only get more and more. And so it's important for all of us to really have a good grasp and understanding about the genetics of cardiac disease. And of course, our genetic makeup is determined in large part by our ancestors. Our genetic makeup determines in part who we are, and it links us not only to our ancestors, but to our immediate nuclear family and our progeny. And of course, genetics has been more and more in the mainstream media. And that's been the case since at least the turn of the century. Back in 2005, the human genome was finally mapped in its entirety. And so it was at that point where we started to develop better ways of assessing specific genes and, of course, genetic variants. And we were able to map not only the entire human genome, but specific disease-related genetic abnormalities. And so this is really what has fueled the major change in our practice when it comes to cardiac genetics. All of this change has led to new guidelines. These guidelines have come out just within the last 5 years. The European Heart Rhythm Association and the Heart Rhythm Society published their expert consensus statement on the state of cardiac genetic testing. The Heart Failure Society of America set out practice guidelines for genetic evaluation in cardiomyopathy. And we're going to talk about these things as we go forward. Of course, the National Lipid Association just recently published a scientific statement on genetic testing for dyslipidemia. And of course, all of this has led to AHA policy statement on genetic and genomic testing in cardiovascular disease, and the policy statement that was just published literally less than 1 month ago in Circulation. And so we're seeing more and more guidelines in our specialties with regard to cardiac genetic testing. And so there is a role for genomics across all of medicine and science, but specifically in cardiovascular disease. And there's a field of research that is incorporated into that genetic evaluation that goes from the individual DNA level all the way up to public and population-based genetic research. And all of these things are ripe for research, not only here, but across the nation. More and more, we're having an increase in both diagnostic, prognostic, and therapeutic capabilities when it comes to cardiovascular disease and genetic testing. And you can see the diseases listed on the left-hand side of this page, including long QT syndrome and catecholaminergic polymorphic VT, Brugada syndrome. There are increasing ways to diagnose genetic abnormalities in these cardiovascular diseases. And more, we're going to see increasing therapeutic interventions when it comes to the treatment of these genetic diseases. And we're going to go into not all of these, but certainly a lot of them as we go on here today. Of course, genetic assessment and clinical evaluation is now at the forefront for many genetically mediated diseases. On the left-hand side here, you see a list of several different types of genetic abnormalities, including variants in the beta-1 adrenergic receptor, factor V Leiden mutations, ACE polymorphisms, cytochrome enzymatic abnormalities, including rapid metabolizers and slow metabolizers, and of course the list goes on and on. And each of these genetic diseases have increasing means of being able to be detected and also treated. And this has led to individualized assessment of patients. And as we go forward, our individualized genetic abnormalities may be part of our medical histories. They may include QR codes that are attached to our helmets as we ride our bikes, but also perhaps in the future, we'll have our clinical abnormalities to be able to be assessed from digital implants that can alert medical providers as to specifically what's going on in our medical histories. So let's talk about some of the basic concepts with regard to genetic testing, and we're going to get right down to the very basics, starting with deoxyribonucleic acid, or DNA. Of course, this is a double-stranded molecule that forms the basis for our genetic makeup, and there are 4 building blocks or nucleotides associated with DNA, and you can see them listed there on the left: adenine, cytosine, guanine, and thymine. And using all of these nucleotides in our DNA, there are 3.2 billion nucleotides in the entire human genome. And as I mentioned, all 3.2 billion were mapped in 2005 and can now be completely mapped within just a couple of hours in each individual. Of course, there's a flow of genetic information that occurs inside each cell in our body. And that includes transcription and translation. Transcription, of course, is the passing or the metabolic copying of our DNA genetic code into RNA, and then translation is the subsequent development of proteins that are based on our genetic makeup. And of course, all of this is the genetic basis for our genes being passed on from generation to generation. Transcription of DNA into RNA specifically includes regions of the DNA that are clinically relevant, and those are the exons. The exons are the areas of our DNA which are subsequently encoded into RNA. The introns, or the intervening spaces within our DNA, are not copied into RNA and are spliced out, so that subsequently, through transcription, we have a messenger RNA that is formed with specific areas of the genome that are encoded and subsequently translated using ribosomes into the development of polypeptides and subsequently proteins that make up our cellular matrix. And so it's by this process of transcription and translation that inheritance occurs. And inheritance takes the form of multiple types, including autosomal dominant, autosomal recessive, X-linked, and maternally mediated forms of inheritance. Of course, there can be abnormalities in our genetic code that cause variations in the code to occur, and that occurs in all of us, but to differing degrees. Those variants take on many forms, and so we're going to talk about the types of genetic variants, including silent mutations, missense, and nonsense variants. And then, of course, all of this leads to different phenotypic expression and penetrance that allows us to manifest our genetic code in clinical ways, right? On the right here, you see a pedigree, and of course, this is a autosomal dominant pedigree. You can see that 50%, roughly 50% of the genetic abnormality is passed on to our descendants, and this is what makes up the autosomal dominant inheritance. So there are different types of expressions of a variant. Of course, there can be a variation in a nucleotide within the DNA that can be transcribed into RNA and then can cause abnormal translation of proteins. And a coding variant is known as a C variant, whereas a variation in protein development is known as a P variant or protein variant. And we use the word variant now in place of the word mutation. A silent mutation is when a specific nucleotide is changed. In this case, we have a change of an adenine to a thymine. But yet the protein that is subsequently transcribed and translated remains the same. So there is no subsequent change in the protein that is translated. And so this is known as a silent mutation because we have no downstream change. A missense mutation is when a nucleotide is changed, but it does result in a change in the amino acid and in the protein that subsequently is translated. And in this case, a threonine amino acid is taking the place of the normal protein that occurred. And this could, of course, cause clinical and subsequent pathologic abnormalities due to this missense variant. A nonsense variant is when there's a change in a nucleotide that actually causes the translation of the RNA and to protein to stop altogether. And this nonsense mutation can truncate the protein that's developed and cause abnormal protein function. So we talked about inheritance, and there are different modes of inheritance based on variations in each of our genomes. And there can be differences in alleles from person to person, and those differences in alleles are passed down by our parents. We can have homozygous alleles that are two copies of the same gene from both parents. We can have heterozygous alleles, different copies of the same gene from both parents. And this is manifest on the chromosome in a certain location where the alleles can be identical or heterozygous. Subsequently, these alleles can be passed down through autosomal dominant or recessive inheritance, depending on the type of gene that is present. Dominant genes typically are expressed only if one of the two alleles is dominant, whereas recessive genes can only be expressed when both alleles are recessive. And that is the reason for blue eyes, for example. And so this is the basic concepts of how our genetic makeup is determined. Just a final word on basic concepts, and that's with regard to penetrance and expressivity. So penetrance is the percent of the variant positive subjects who exhibit the objective phenotypic marker that defines the presence of the genetically mediated disease. And so if a specific gene is 80% penetrant, then 80% of the people who have that gene will display the phenotypic results. Expressivity, on the other hand, is relative capacity of a gene to affect the phenotype of the organism of which it is a part. And so there are different, basically, shades of expressivity. To strong expressivity, where the phenotypic response or the phenotypic result is evident, as opposed to a weak expressivity, where the phenotypic outcomes may not be as apparent. And so this is a pedigree that is an example of autosomal recessive inheritance. You can see that the females that are demarked by a circle and the males demarcated by a square. When the square and circle are half shaded, it means that they are carriers of a specific recessive gene. When a male and female who are both carriers uh, have children, there is a 25% chance that their children will have the genotypic, and then subsequently the phenotypic abnormality associated with the genetic variant. This, by the way, is an example of a patient with cystic fibrosis. Let's talk a little bit about genetic testing. Of course, there's a timeline to genetic testing that goes back to 1953 when Watson and Crick discovered DNA, and that goes through the development of different types of DNA testing, including DNA sequencing, which first was developed in 1977. And then subsequently, the Human Genome Project began. That was in 1990. And it was in 2003 that the first draft of the Human Genome Project was published. In 2005, we developed the next generation of sequencing that allowed for more rapid determination of our genetic makeup. And that is what's fueled really this new age of genetic testing and therapeutic intervention. In 2015, the FDA approved next generation sequencing for clinical diagnostic applications, and that's what's led us to today. Next generation sequencing, of course, it was developed in 2005, allowed us to target specific genes for assessment in each person's individual genome. And so next generation sequencing, or NGS, of a focused panel of specific genes then took place. It involves targeted assessment of specific genes and coding regions, the exons specifically, within the human genome. And of course, we also have whole genomic sequencing, which can occur, and that's the 3.2 billion DNA nucleotides of the entire human genome. And so we extract DNA from our subject, and through fragmentation and massive parallel sequencing, we can specifically look at specific areas of the genome, specific areas of an individual gene through computational analysis, and can determine whether there is an abnormality in a specific nucleotide. And that's what next generation sequencing allows. So we can look for single gene or disease-specific genes in a specific gene panel. We can assess when an individual patient has a specific gene based on a phenotype that they're displaying. We can look at large areas of codons, large areas of arrhythmogenic or cardiomyopathy genes, for example, that are typically indicated when a patient has an undifferentiated phenotype, and where molecular insights could further refine our diagnostic ability. And then we have the ability to look at the whole exome of genomic sequencing and looking for specific diseases or polygenic risk. And so we're going to spend some time discussing monogenic versus polygenic assessment of the genome and how it relates to our ability to diagnose specific diseases. And we'll then look at specific monogenic genes that we all need to know about in going forward in cardiovascular medicine. So let's take a moment and talk about monogenic versus polygenic. So when we speak about monogenic disease, we're talking about Mendelian inheritable diseases, usually caused by a mutation in a single gene, but can be dominant, recessive, X-linked, or maternal-linked, and it's less common than polygenic disease, extremely rare, but with strong phenotypic expression, typically. Polygenic genetic abnormalities are non-Mendelian, These are disorders that are caused by combinational effects of both gene mutations and environmental factors. Multifactorial uh, assessment is imperative when speaking about polygenic assessment. And these typically include many genes, but that are less expressed phenotypically and can be associated with large diseases such as essential hypertension, type 2 diabetes, and coronary artery disease, for example. So GWAS is a genome-wide association study. And GWASs take the entire genome. You can see the chromosomes are listed here on the x-axis from 1 to 23. And they look for specific areas of the genome that are associated with disease. They use what are called single nucleotide polymorphisms, or SNPs. These SNPs are located across the genome and serve as genetic markers of abnormalities within the genome, variants that occur that can be associated with disease. And so SNPs are relatively common. They occur in up to 5% of the population studied. And there have been described over 150 million SNPs in populations across the world. SNPs, again, are single nucleotide polymorphisms that are associated with disease. And so we can look at different types of diseases, and we can discuss whether they're monogenic or polygenic. Cystic fibrosis, for example, is caused by a variant that occurs on the Q arm of chromosome 7. It's an autosomal recessively inherited disease and requires two pathogenic alleles to be present in order to be expressed phenotypically. Whereas polygenic abnormalities include variants across the entire genome and may include thousands, hundreds of thousands, even millions of genetic variants that have been associated with specific diseases like coronary artery disease. And it's the assessment of these polygenic predispositions to specific diseases like hypertension and coronary artery disease that have led to the development of what are called polygenic risk scores. And of course, polygenic risk scores have been around for quite a while, but they haven't really been used clinically to much degree. But there is an important point to be made about polygenic risk scores. In one study, in over almost 500,000 adults, genomic risk was assessed looking at specific Framingham risk factors and then adding in these polygenic risk scores. These are variants that are present throughout the genome that have been associated with coronary artery disease. And what this study in 500,000 patients showed is that that polygenic risk scores, in this case meta-GRS, have a higher ability to predict the presence of coronary artery disease as well as outcomes. There's a greater association with future coronary artery disease event with polygenic risk scores that are positive than any single conventional risk factor. And that is even more the case when you combine the risk factors with the polygenic risk score. And it provides a meaningful lifetime risk estimate for the likelihood of developing coronary artery disease. And that is particularly the case when you look here at risk factors associated and combined with the polygenic risk score that had the highest cumulative risk of the onset of coronary artery disease. They've also looked at the risk of premature atherosclerotic disease in patients with monogenic versus polygenic familial hypercholesterolemia. And when you have polygenic risk of coronary artery disease associated with a monogenic variant that's causing familial hypercholesterolemia, you have the worst prognosis of all, with an event-free probability of having an event being the lowest in patients that have both monogenic variants with a polygenic risk score. And you can see here with both monogenic and polygenic risks, your hazard ratio is the highest with a threefold increase in the presence of disease. And so this led to a scientific statement published by the American Heart Association that said that it's likely a matter of when and not if polygenic risk scores for both common polygenic and rare monogenic disorders begin to make their way into clinical practice. So I think, the place to use polygenic risk scores may be in those patients who have have a family history of premature coronary artery disease and myocardial infarction. They're really interested in where their risk is. In that sense, they're somewhat similar to coronary calcium scoring in those patients who really want to try to define their individual risk. Let's shift gears a little bit and talk about monogenic testing. And let's first talk about atrial fibrillation. Atrial fibrillation is not really considered to be a monogenic disease. But what's interesting about AFib is that there is an association between early onset atrial fibrillation and the presence of monogenic causes of cardiomyopathies. There was a paper in JAMA that looked at Titin loss of function variants and showed that in at least 7 different SNPs, there was an association between the presence of these genetic variants associated with cardiomyopathy and the early onset of atrial fibrillation. And so if you have someone in their 30s, 40s, and 50s who have developed atrial fibrillation for reasons that aren't clear, and you can't find an abnormality on their evaluation, you may want to consider genetic testing for one of the genetically mediated dilated or arrhythmogenic cardiomyopathies, because it seems as though that there's a relationship with the presence of atrial fibrillation in patients who carry genes like the Titin gene, early onset AFib. And so we'll be talking about different genes specifically as they're related to monogenic causes of pathology. And of course, the Titin gene is here. And it's interesting that the Titin gene is an overlapping gene that can manifest itself as hypertrophic cardiomyopathy, a dilated cardiomyopathy, or even arrhythmogenic cardiomyopathy. And so atrial fibrillation is one of the atrial arrhythmias associated with the expression of the Titin gene. Let's talk a little bit about channelopathies. And of course, we have several different channelopathies that are genetically mediated, including sudden infant death syndrome, sudden unexplained death, Timothy syndrome, dilated cardiomyopathies, long QT syndromes, and short QT syndromes, idiopathic ventricular fibrillation, Brugada syndrome, and CPVT. And so these channelopathies all have specific risks associated with them. But when you look at patients who've had sudden cardiac arrest or aborted sudden cardiac death, the vast majority of them have coronary heart disease, particularly in adulthood. But there's a significant proportion of them that have cardiomyopathies, non-ischemic dilated cardiomyopathies, hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, etc. And you can see that over the span of a lifetime, that early onset of sudden cardiac death is often associated with arrhythmogenic genetically mediated abnormalities such as long QT syndrome and catecholaminergic polymorphic VT. As we get a little older, we may see hypertrophic cardiomyopathy or arrhythmogenic right ventricular or biventricular cardiomyopathy start to show signs of arrhythmogenic abnormalities. And then, of course, as we pass age 35, it's much, much more likely that our sudden cardiac death episode is going to be related to mechanical or coronary causes. And so we're going to take a little bit of time to speak about the channelopathies in this age group. And of course, the channelopathies are one of the main causes of sudden cardiac death in athletes. Of course, hypertrophic cardiomyopathy being the most common cause in the United States, with 35 to 50% of patients who had sudden cardiac death as a young athlete manifesting hypertrophic cardiomyopathy. And of course, arrhythmogenic right ventricular cardiomyopathy is a cause of sudden cardiac death, especially in the Mediterranean countries. Back in 1988, when I had dark hair, there were very few genetically mediated causes of sudden cardiac arrest that were definable. And so long QT syndrome, which accounted for up to 20% of sudden cardiac deaths, and CPVT up to 9 to 10%, but the rest were considered idiopathic. Over the years, there have been more and more genetically mediated causes that have been defined and that can be defined now easily with genetic testing. And so more recently, we have multiple genetic abnormalities that are associated with sudden cardiac death. But let's talk a little bit about idiopathic ventricular fibrillation. And of course, the guidelines state that in patients who have had an aborted sudden cardiac death or evidence of idiopathic VF, that genetic testing can be useful, especially when there's a suspicion of specific genetic diseases following a clinical evaluation. All patients with idiopathic ventricular fibrillation should be evaluated for underlying causes, the genetic causes, and this is a class 1 recommendation. Exercise stress or catecholamine provocation testing should also be performed, and that's to rule out CPVT. And in young patients with unexplained sudden cardiac arrest who do not have ischemic or other structural heart disease identified, further evaluation for genetically mediated arrhythmia syndromes is recommended. And indeed, when you look at idiopathic VF, many of them have genetic abnormalities. And in those that do have genetic abnormalities, over half of them have variants that have caused channelopathies, and up to 42% have arrhythmogenic cardiomyopathies, including the RYR2 gene, which is one of the most common causes of channelopathies. That's an abnormality in calcium exchange, which increases intracellular calcium and predisposes the patient to arrhythmia. The SCN5A gene, of course, a ubiquitous pathologic variant that's been associated with multiple abnormalities, as we're going to talk about, but of course is an abnormality in the sodium channel. And then, of course, the KCNQ1 and KCNE1, these genes are associated with long QT syndrome. And so we're going to spend some time on each of these. The arrhythmogenic cardiomyopathies, the Titin gene is the most common gene associated with arrhythmogenic cardiomyopathies by far and away. It may be the number one cardiomyopathy gene. Of course, that's the largest protein in the body. And so we'll speak about that when we speak about cardiomyopathies. Of course, the lamin A and C gene also a very prominent role in the development of genetically mediated dilated cardiomyopathies. And so this is an EKG that you never want to miss. The fellows, this needs to raise a red flag when you look at it. And of course, this patient has significant QT prolongation and is at risk. And so we're going to talk about long QT syndrome. And of course, when you have someone with long QT intervals, you want to rule out secondary causes. But if you've ruled them out, then monogenic testing is reasonable, as the incidence of long QT syndrome is at least 1 in 2,000, which is relatively common. Many of them won't have long QT intervals, but of course, if you see it, you want to look for it. And many of the patients that have long QT syndrome do not develop torsade. So the vast majority of them may not have clinical manifestations of arrhythmia, but certainly some of them are at greater risk, and we're going to talk about that. Long QT syndrome was first described by Jervell, Lang, and Nielsen in 1957. In 1995, we started to describe specific channelopathies, and now look how far we've come in just 30 years in developing all of the different genetically mediated channelopathies that we know about today. Of course, there are different types of ionic variations that can lead to long QT syndrome, but the most common one is a loss of function variant in voltage-gated potassium channels and also leaky sodium channels. And while there are 18 genetic variants that describe long QT syndrome, the big three are LQT1, 2, and 3. And so about a third of long QT syndrome will be LQT1, a third will be LQT2, and then less often LQT3. So the guidelines suggest that everybody that you suspect long QT syndrome in should have a scoring done. It's called the short score, and it allows for assessment of the different clinical variables that are associated with long QT syndrome in order to make a more accurate diagnosis. Of course, the guidelines also suggest that in the presence of unequivocally pathologic expression or mutation in one of the LQT genes, that you can make the diagnosis, or in the presence of a QTC interval of greater than 500 in repeated 12-lead EKGs. And so on the right, you see the short score. And of course, you get varying different points. If your QTC interval is greater than 480, you get 3 points. Of course, if you have a 4-minute recovery of QTC after exercise, you get a point. The presence of torsade gives you 2 points, and then et cetera, et cetera. If you have a syncopal event with stress, you get 2 points. And of course, you just need 3.5 points to make the diagnosis. The short score can be downloaded in an app, the Long QTC scoring app, and you can get that through the App Store. So it's important to point out that a negative genetic test does not completely rule out the diagnosis of long QT syndrome. But to diagnose, a phenotype must be present. And if you do get a positive pathologic variant with genetic testing, it is helpful in diagnosing the disease. The clinical approach to long QT syndrome includes historical evaluation and pedigree, an ECG and an exercise ECG, and of course genetic testing, which is a class 1 recommendation in patients in whom you suspect long QT syndrome to exist. The diagnosis includes both genetic testing, the short score, and of course a QTC interval of greater than 480 milliseconds. And of course, treatment, as you know, varies depending on what type of genetic abnormality you have. Long QT syndrome 1 is very responsive to beta blockade therapy and typically is treated with nadolol, which has a long half-life and is very cardio-specific. Of course, long QT 2 and 3 may respond to mexiletine. And of course, many of these patients, particularly if they have aborted sudden cardiac death, are considered for ICD therapy. Don't forget in your patients who have a pathologic variant that there should be cascade screening of the family to make sure that they also are not manifesting the abnormal gene. And as I said earlier, there have been 18 long QT syndrome genes that have been described. And of course, the yield is 80%. If a genetic test is negative, the phenotype has to be strong in order to make the diagnosis. And so our long QT genes are here, including the KCNE1 gene and KCNQ1, the KCNH2 gene, and then SCN5A, which is Jervell-Lang-Nielsen. Let's talk briefly about the cardiomyopathies. ARVC has a prevalence of 1 in 2,000 to 5,000. There's a male predominance. It's predominantly a fibrofatty infiltration of the right ventricle, but can also include the left ventricle. ABVC is probably a better acronym for arrhythmogenic biventricular cardiomyopathy. And of course, it's autosomal dominantly inherited usually, and is caused by variants encoding desmosomal proteins typically, and can account for 17% of all cases of sudden cardiac arrest in young adults. Of course, the evaluation here includes not only a history and pedigree, but also an EKG, a signal average EKG to look for late potentials, and ambulatory monitoring, as well as obviously non-invasive imaging and genetic testing. And of course, there are major and minor diagnoses that I'll have you guys take a look at. But the risk stratification includes established markers, including episodes of VT, VF, and cardiac arrest, but also cardiogenic syncope, etc. And of course, pharmacologic treatment may include beta blockade and antiarrhythmic therapy. These patients should avoid exercise, as exercise can certainly lead to arrhythmia, and it is, of course, a common cause of sudden cardiac death in athletes. These are the major and minor criteria that I'll have you guys take a look at, but they include regional dysfunction noted on cardiac imaging, histopathology, repolarization abnormalities, and of course, arrhythmias and family history. And it's important to point out that the gene that's most associated with arrhythmogenic right ventricular cardiomyopathy is the plakophilin-2 gene. To get MOC credit for this talk, you may want to remember that it's plakophilin-2 that has been mostly associated with ARVC. And of course, the arrhythmogenic cardiomyopathy genes are here, but overlap with hypertrophic and dilated cardiomyopathy, and can cause both weakened left ventricular systolic function and right ventricular function, as well as arrhythmogenic death. Let's talk about monogenic testing with other arrhythmogenic cardiomyopathies. We talked about lamin A and C that can cause both atrial and ventricular arrhythmias. There's a male predisposition, and these patients often have non-sustained ventricular tachycardia. Filamin C and phospholamban are different types of arrhythmogenic cardiomyopathies that can cause biventricular cardiomyopathies and are both have high malignant arrhythmogenic risk. And of course, desmoplakin is another gene that is associated with arrhythmogenic cardiomyopathies and can be PET positive. And then I want to point out that the Newfoundland gene is highly arrhythmogenic and typically will cause sudden cardiac death even in prepubertal males. And so if you do find a Newfoundland gene when you're doing genetic testing, that you want to consider an ICD in males even at the time of puberty or before. Let's talk a bit about dilated cardiomyopathies. And so there are idiopathic, familial, and genetically mediated dilated cardiomyopathies. Idiopathic is a primary myocardial disease of unknown cause characterized by ventricular dilatation and impaired myocardial contractility, whereas familial dilated cardiomyopathy are when two closely related family members meet the criteria for dilated cardiomyopathy, or a first-degree relative who had a sudden cardiac arrest before the age of 50. And genetically mediated dilated cardiomyopathies, as the term would imply, are dilated cardiomyopathies that occur when a genetic cause has been identified. The epidemiology of this is a 36 case per 100,000 incidents, with a prevalence of 0.4% in the general population. 36% of all cases of heart failure are monogenic dilated cardiomyopathies. And of course, there are multiple genes associated with dilated cardiomyopathies, including the Titin truncation variants, the Titin gene being the largest known protein in humans, and it spans across the sarcomere and plays a critical role in force transmission. But there are multiple other genes that are associated with dilated cardiomyopathies, including the myosin heavy chain genes, cardiac muscle troponin, alpha tropomyosin, of course, desmoplakin, desmosomal cardiomyopathies, and lamin AC, which helps to form the laminated shell around the nucleus. And so I'm going to wrap up here shortly. Of course, dilated cardiomyopathy genetic sequencing can help to find these genes. The vast majority of dilated cardiomyopathies will have a Titin gene abnormality, but there are multiple genes that also can be found and can be associated with disease. And patients who are genetic positive have an increased likelihood of adverse cardiovascular events, as well as end-stage heart failure, and this is statistically significant. As we move forward, we'll probably integrate genomic abnormalities and the so-called omic abnormalities into novel, precision, individualized approaches to the treatment, diagnosis and treatment of heart failure. And of course, they were before their time, but Dr. Narula and his colleagues in July 2014 advocated for including genetic testing in the nomenclature when it comes to describing cardiomyopathies. We haven't done that because it's become more difficult, but I think with the advent of AI and the ability to more easily test for these genetic variants, that we'll be able to integrate genetic abnormalities into our assessment of the patient with heart failure. And of course, the dilated cardiomyopathy genes are denoted here and include all of the ones that we just mentioned, including the Titin gene, as well as the lamin gene. And SCN5A, of course, is everywhere. Just a word about ATTR amyloidosis. There are multiple genes associated with hereditary ATTR amyloidosis. And of course, they vary the spectrum between predominantly neurologic abnormalities and predominantly cardiac abnormalities, with some over mixing of all of them. And it's important to point out that when you determine that your patient has ATTR amyloidosis, that there is a class 1 indication for genetic testing. So don't forget that genetic testing is indicated. And of course, in patients with hereditary transthyretin amyloidosis, if you look at their relatives at risk, up to 200 of them, 43% of the studied relatives were genetic carriers. And of those genetic carriers, 33% were initiated on specific treatment up to 10 years earlier than the proband in their family. And so you can use genetic analysis of family members to initiate treatment sooner in order to treat patients more effectively. Hypertrophic cardiomyopathy is a disease of the myofilament. There's a great incidence worldwide. And of course, there are multiple genes that are associated with hypertrophic cardiomyopathy, including the myosin binding protein and myosin heavy chain protein genes. Please remember that genetic testing, once again, is a class 1 indication in patients who are suspected of having hypertrophic cardiomyopathy based on their history and testing, and that patients that are genetically positive should have cascade testing of their family members. Patients who are genetically positive but phenotypically negative need to be undergo surveillance on a every 1 to 2 year basis because they may develop the disease. Here is a case of different type of penetrance and expressivity in the same family with hypertrophic cardiomyopathy. This is the parent, father, who's developed such a gradient, intracavitary gradient, that he's developed a burned out apex. His son and daughter both have hypertrophic cardiomyopathy. This daughter is genetically positive but phenotypically negative and needs to be followed closely. And of course, there are clinical markers for positive hypertrophic cardiomyopathy genetic test. And what's important to point out is that the more clinical markers you have that are deleterious, an age of diagnosis of less than 45, a family history of hypertrophic cardiomyopathy or sudden cardiac death, the reverse curve phenotype, the more of these that you have, the worse your prognosis, the greater the yield of genetic testing. And of the patients who are genetically positive for hypertrophic cardiomyopathy, there is a worse prognosis, as I mentioned. And that's statistically significant. And so genetic testing can help you determine prognosis in patients who are diagnosed. Just a word about hyperlipidemia. Of course, heterozygous hyperlipidemia is very common, genetically mediated hypercholesterolemia in 1 in 250 incidents, but homozygous is rare. There may be only 9 homozygous familial HC patients in the state of New Jersey. Of course, as we go forward, we're going to be testing more for genetic abnormalities in the lipid clinic, including patients with Lp(a), familial hypertriglyceridemia, and of course, ApoA and ApoB. And of course, right now, we look at primarily 3 specific genes for familial hypercholesterolemia: the LDL receptor gene, ApoB, and PCSK9. And those are the ones that we look for in patients who we suspect have familial hypercholesterolemia. Those are patients that have LDL cholesterols typically of 190 or higher. And of course, in those patients, when you're genetically positive, you have a higher odds ratio for the development of coronary artery disease. In patients who have LDLs of greater than 220 and are genetically positive, there's up to a 25-fold increase in CAD. That's a lot. And of course, in patients, once again, who have monogenic and polygenic risk scores that are both positive, they have the highest incidence of disease and the worst prognosis. Here at Rutgers, we're developing the Center for Preventive and Genomic Cardiology. And that's going to include multiple different sectors, so to speak, beginning with preventive cardiology, but also cardiac genomics. We will have a clinical PharmD, hopefully, eventually, that will be helping us in this clinic. We'll work with the infusion center for our genetically mediated treatments. We're developing a cardiometabolic program together with our colleagues from endocrinology and nephrology. That's in the works. We'll also work with our colleagues from bariatric medicine, and hopefully will allow patients to have improved medical and surgical options for weight loss. We'll work with dietitians, and of course, we will include sports cardiology. And taking all of those together, we include clinical and translational research, which will be the focus of what we do in the Preventive and Genomic Cardiology Center. And that is it.
Thank you very much, Jim. And if you will unshare your screen, we can have a discussion. So I think I have a couple of questions already there. Dr. Halava is asking, he's complimenting your talk. Actually, it was a fantastic talk, Jim. I must say that it was very long but very comprehensively covered and very nicely done. And I'm sure this will be a great repository in our YouTube where people can go and learn and get all the insights in one lecture. What is your approach to sudden cardiac death patients' family who have positive gene but no clinical presentation? I'm specifically asking about myosin have MYH7. I don't know what the full form is, gene for HCM. It should be myosin YH. I don't know.
Right, MYH7. Right. And so the question is, if they're genetically positive, but phenotypically negative, should we be intervening on them? And, the jury, I believe, is still out on that. I mean, it's certainly being debated. Uh, uh, I think that if you have no strong phenotypic expression, no incidence of sudden cardiac death or arrhythmias, that it may be premature to intervene. But certainly you want to monitor these patients closely. Of course, all of them should have exercise testing, I believe. They should have ambulatory monitoring performed. And I would even go so far as to consider a loop recorder. Yeah.
Yeah, so Zishan actually corrected myosin heavy chain 7. Anyway, so thank you very much. Then the second question is coming from Dr. Magandi. What are your thoughts regarding VUS? How can we help with reclassification?
Yes. Well, there are specific ways to reclassify patients, and there are specific computer programs that are now available to help us in that regard. There are actually multiple programs available. And so I can discuss, if any of you are interested, we can discuss the different programs that are available to help to reclassify patients. But I think that you have to put it into clinical context. You have to look at their phenotypic expression. You have to look at how likely you think that they have a possible genetically mediated abnormality, and then use some of these computer-based AI programs to help swing that pendulum toward a pathogenic variant versus a non-pathogenic variant. And so we take everything at our disposal and try to make the right call. I would also suggest that they be retested in the future because there's constantly updates to the genomic testing system and upgrades in our ability to determine whether a specific variant is pathologic or not. And so, as part of their surveillance, they should be retested.
Great. I think we have Dr. Zishan Ahmed and Dr. Yanamala also here who actually do a lot of the work in genomics and they will be doing a lot of the work also for the rare disease center where this will be an important consideration. One question that I want to ask Jim is I know that the whole exome sequencing cost is going down remarkably. So would there be in the future a potential time where people in health will get it done and know their underlying risk, and accordingly they can modulate their lifestyle, knowing what is going to come, knowing what kind of genetic variations they have. How far are we away from that? I know that you don't want to create some kind of paranoia that you have all these sequences that are abnormal, but is there any study or any knowledge that if you know about a genetic predisposition, most of the time from your familial history, you could get that sense. But actually, if you do that test, given that it is now easily possible to do, is there any value, do you think, in future for mass level um,
Population based.
population-based, targeted screening or something that could lead us to helping us design better care?
I believe that's true. And, uh, it's going to be tricky, of course. We have laws that have been passed. The GINA law, of course, was passed over 10 years ago that protects patients from being denied health insurance, of course, when they have genetic testing. But unfortunately, that doesn't apply to life insurance yet, right? And so those types of things I think will play a role in those population based genetic screens. We're going to have better insight and laws passed regarding that. But for example, many of the causes of sudden cardiac death in athletes are genetically mediated. And so I envision a point in time when genetic testing is so readily available and inexpensive that it could be used as a means of um, excluding young people that have monogenic pathologic variants. And so that's just one example where it could be used on a population basis. And with regard to coronary artery disease, I think polygenic risk scores can be helpful. But in patients with, as you mentioned, family histories, uh, I mean, just look at the prevalence of coronary artery disease alone. I think that if we're going to make inroads into coronary artery disease, we're going to have to start to think along these lines, along the metabolic and genetic lines. And if we do that, I think we'll be able to intervene sooner and we'll be able to reduce the incidence of disease.
And for example, like, based upon that setting, you would decide what is the threshold of your LDL or LPA that you want to use. Because, for example, I've seen that Lipid Association of India, for example, has recommended an aggressive LDL even lower than 55, 50. We don't have that recommendation here in the US.
Yes.
But we
It's
know,
coming.
at least I know that South Asian people get coronary artery disease at much lower levels of LDL. But what I'm saying is that the underlying genetic makeup could change the targets of how you're going to manage different types of um, expressions of diseases or pharmacological interventions or thresholds at which you will intervene with medicines. So that will be interesting. So I think Dr. Ahmed has a question. Great talk. Would you request your thoughts if there is a gene without notable variant, whole genome based, but significant expression RNA sequence based in the same patient at the same time? Furthermore, your thoughts at difference between blood and tissues sample sequencing. I was also thinking about that. How do you get actually where it matters the most? Because you're not collecting it from the heart or the coronaries or somewhere else where it may be expressing completely differently. You're collecting it from somewhere else, blood or sputum or I don't know.
Yeah. That's a great point, and I don't know that I have the right answer for that, but I do believe that you know most of these genetic variants are found within just cells outside of the cardiac, you know, outside of the heart, and so I do believe that in some cases, uh, cardiac tissue might be helpful, but with regard to the complications associated with myocardial biopsies and the like, uh, I, I, I have to think that we'll probably not be going down that path anytime soon.
Mm.
Yeah.
Yeah. All right. I think we are already 12 minutes past the hour. And thank you very much, Jim. I think we will. Zishan, did you have a question you wanted to ask? You can.
Yes, thank you so much
Yes.
for the opportunity. Dr. Mills, a great talk. I loved it. It's really informative. I wanted to have your thoughts about that. We recently are conducting some analysis where we have done, sequencing of various kinds using the blood sample of the patient, like we have done RNA-seq, using the same sample. We did whole genome sequencing. We have also generated their metabolomic profiles. So one of the situation we are facing, and that is like we are getting no notable or important variant relevant to the disease. However, we are getting significant expression uh, in the patient. So that's what I requested in my question. What do you think about that? If there's no variant but expression.
Yeah. Well, that's where I think that if you have a strong phenotypic expression and you still believe clinically that the patient is manifesting signs of genetically mediated disease, that it's I believe that that would push you more toward it being a likely pathologic variant. And I do think that there are going to be more and more AI associated uh, methods to help us recategorize patients as we go forward. And so I think those patients have to be treated more aggressively if they're showing phenotypic expression. And I think that they need to be followed more closely. We should do our due diligence with regard to reclassification. And then, of course, they should be retested. Wouldn't give
Very
up.
good. Yeah. Thank you very much, Jim. Thank you, everyone. I think this is going to be recorded and available. So we look forward to the part 2 in May. And with that,